Good morning. I'm Red Schiller. Here we are. I'm Red Schiller. I'm president for academic affairs at the Institute for Family Health, a family physician, and vice chair of the Department of Family Medicine at Mount Sinai. This is our grand rounds, and we are delighted to have one of our usual presenters, Dr. Joseph Lurio, one of our own. Today he's going to give us an update on buprenorphine and inform us about more of the innovative ways of dealing with opiate use disorder in the age of fentanyl. You probably have memorized his background, but I will recite it anyway for those who are joining us. Joe is director of the Addiction Medicine Fellowship at the Institute for Family Health and associate professor of family medicine at the Icahn School of Medicine at Mount Sinai. He has over 30 years of clinical experience as a family physician in underserved communities and is one of our family physicians seeing patients at the Amsterdam Family Health Center. As part of his family medicine practice, Dr. Lurio provides medication-assisted treatment for opiate dependence and other addiction services. His interest in addiction began while performing anthropology fieldwork in New York's Bowery as an undergraduate at Columbia University, just a few months ago, as a matter of fact. Later during he's an experienced physician. Later during his tenure as a physician in the Indian Health Service, he broadened his experience treating alcohol, inhalant, and opioid use disorders. And then when he returned to New York, published research in screening pregnant women for illicit substance use and participated in early trials of primary care office-based methadone maintenance work at the Institute. He developed a collaborative care model with a mental health and primary care treatment in the early 2000s that led to the adoption of buprenorphine maintenance into his practice. He continues to champion an integrated substance use identification and treatment into primary care. Dr. Lurio's research interests have focused on addressing substance abuse and immigrant medicine, as well as the field of medical informatics, which deals with technical problems in maintaining and coordinating care. His early research has been cited in CDC protocols, and recently his work in linking public health and primary care via electronic health records has acted as a proving ground for protocols implemented by the New York City Department of Health and Mental Hygiene in their primary care health information project. Joe, it's always a delight. Keep us informed with this ongoing challenge, public health and primary care issue. Take it away.
Okay. So let me share my screen. Thanks a lot, Red. And okay. So, okay. So can people see my first slide? Give me a thumbs up or?
Yes.
Okay, great. All right. So as Red said, the title of this talk is an update on the use of buprenorphine, an initiation and management of buprenorphine for people with opiate use disorder in the age of fentanyl. So really, this is going to be a summary of the things that I've learned at the recent conference of the American Society of Addiction Medicine. And let me start with some disclosures. About 50% of my salary comes from direct patient care. 40% is from teaching, family medicine residence, and addiction medicine. And 10% is from a grant from the NIDA. And I'm not mentioning the NIDA grant to brag. I'm only one of a number of local PIs in the national multi-site prospective trial. The point is that NIH is investing big money now in generating high-quality scientific evidence, not regarding the biochemistry of addiction, which is what they've invested in the past, but instead for treatment modalities, to improve patient-centered outcomes, an important development informing our ability as healthcare providers to effectively care for these patients. Now, from as far as bias is concerned, hold on a second, let's see. Right. I have to admit that I am biased against big pharma in general, but certain companies in particular tick me off. Alkermes, which is a maker of Vivitrol, really angered me in their duplicitous marketing of Vivitrol for opiate use disorder. I do prescribe a lot of it for alcohol use disorder. But listen, this talk is about buprenorphine, which is a much more effective treatment for opioid use disorder. So I'm not going to mention Vivitrol at all. But I do have to mention that I have a personal contact with one of the founders of Purdue Pharma, Mortimer Sackler, who I called Uncle Morty, not because he's my uncle, but he was a uncle of one of my college chums. So that's what I call him. And besides hosting me for dinner a couple of times before I started medical school, he, along with his brothers, was involved in the development and marketing of extended release oxycodone and morphine, OxyContin and MS-Contin. And in marketing that, starting in the mid-1990s, they had a large part in fueling the opioid epidemic, which we are continuing to have to deal with. So more about Uncle Morty later. And credit where credit is due. Most, if not all, this information comes from the people who have been doing tremendous research of higher and higher quality. Over the years, they presented at ASAM, and really I've borrowed most of my slides from them. You'll see that there'll be the ASAM logo in the lower left corner to show the slides which I've purloined. And of course, thanks to Dr. Panthappattu, Tarr, and Urdanigo for helping me cover this meeting and summarize these the presentations over those 3 days of the conference. All right, so before we get into buprenorphine, it's helpful to quickly look at the epidemiology of the opioid crisis and what we're trying to deal with from a primary care perspective. I mean, we all know about this stuff, but I think it's important to look at the 3 phases of this particular epidemic. The first one was following 5 to 10 years of very strong promotion by Big Pharma. We were having more and more people with chronic pain who had become addicted to opioids, and then starting in the 2000s and increasing pretty quickly over the decade, more and more people were showing up dying from opioid overdoses. Primarily, that increase was from prescriptions that we were writing. Now, phase 2, after about 10 years, we as a medical profession started to get wise to this particular scam, started pulling back on prescribing opioids, and then the what I call the unethical pharmaceutical industry stepped in to fill the needs of the patients that we addicted, and there started to be a rise of deaths from heroin. And then in phase 3, in a response to very strong efforts to interdict importation of heroin into the United States by the government, and also economic pressures, synthetic opioids started being introduced into the drug stream, and especially fentanyl, and you started seeing a rise in deaths from synthetic opioids, which then turbocharged the number of deaths from overdose. And of course, with the pandemic, things only got worse. So let's talk a little bit about fentanyl, which is the primary synthetic opioid, which is fueling deaths from overdoses. Now, fentanyl is a rapid onset, especially when it's given IV. It has a very short half-life compared to heroin. And because of that, anesthesiologists love it. It's great for inducing anesthesia, and it doesn't last very long. So people are not sitting in the recovery room for very long. They can be moved out and back onto the ward. So it's a great opioid for inducing and maintaining anesthesia. For the same reasons, pretty much addicts hate it. I mean, the short half-life, it means that instead of using heroin 2 to 3 times a day, some people are using fentanyl every 2 hours to be able to maintain a high or prevent withdrawal symptoms. One of the reasons why it's such a deadly drug, street drug, is because it's so potent. It's 80 times gram for gram the potency of morphine, which makes it very cheap and easy to smuggle. Instead of people trying to smuggle bricks of heroin across the border, you can take some fentanyl, put it in an envelope, and mail it, and then dilute it. But that also means small errors in measurement can result in very large effect variations, especially when people are packaging fentanyl for retail. They're using a kitchen scale, which maybe has the tolerance of a gram plus or minus at best. And that amount of difference can be the difference between having just a potent high and a fatal one. And the other thing which is important for us as physicians to understand is that with long-term use, because it's highly lipophilic, fentanyl leads to bioaccumulation in the adipose tissue and a very, very prolonged metabolite excretion. Even though the half-life is 3 hours, you can have people who will still be excreting fentanyl and its metabolites for a week after they've ceased use. And that's going to interfere with our ability to get people onto buprenorphine. And we're going to talk about that a little bit more. Here's a little picture of the variable potency, heroin, fentanyl, carfentanil. There's not too much carfentanil being distributed, but the fentanyl is really primarily what's out there. And the Department of Health is telling us that they're not finding any powder that's being sold as heroin that isn't primarily fentanyl in New York City, at least. All right. Before we get on to buprenorphine, I think it's very important to take a look at exactly why fentanyl is creating such profound tolerance. And that is related to its ability to dissolve into adipose, into fat, and actually get intracellular. If you have morphine, which is attaching to the mu or delta opioid receptors, it sits on the receptor, activates the receptor, but that's where it stays. Fentanyl can be internalized. And because of that, it makes changes not only in the number of receptors, I mean, downregulating the receptors, which happens with morphine or other opioids, but it also changes the response to those receptors in the internal biochemistry of the neuron. And that change creates levels of tolerance, which really we haven't seen previously. So people who previously could be stabilized on 90 to 120 milligrams of methadone a day are now needing greater than 200 milligrams to be not showing signs of withdrawal. Certainly, craving is not controlled until very, very high levels, and that can be very problematic in treating these patients. All right, so enough about fentanyl. This talk is about buprenorphine. So, as we all know, buprenorphine is an effective treatment for opioid use disorder. This slide summarizes the effects of the benefits of buprenorphine. I'm not going to read the whole slide. I mean, listen, we've all had our training to get our X waivers before that requirement was eliminated a couple of years ago. But one thing that I want to point out here, which is kind of interesting, if you're looking at the coverage of the opioid receptors with different levels of buprenorphine, by the time, I'm sorry, hold on, let me get back here. Um, can I go back? At any rate, I'm not gonna go back there. But the problem is you're covering more than 90% of the opioid receptors with 16 milligrams of buprenorphine. So why are we having to prescribe 24 and 32 milligrams now? All right. I think that is a big problem. And I think it's because it's not just covering the opioid receptors, but stimulating the downregulated receptors because of the internal changes fentanyl has caused in the opioid regulatory system in the neuron. All right. But the bottom line here, as far as buprenorphine, is that buprenorphine or methadone medications for opioid use disorder reduce mortality by 2/3. That's 66% of patients who would otherwise be dying of overdoses are being protected by this medication. There is no other intervention we have in primary care that comes close to this efficacy in reducing all-cause mortality. Mammograms, colonoscopies, treatment of hypertension, none of this comes close to that kind of efficacy. All right. And it's in our power as primary care providers to be able to give this prescription. All right. So back in the early 2000s, when I was first certified and later mentored to prescribe methadone, I was taught a number of things that are no longer accepted as being valid. Those are buprenorphine can be used to detox an opioid-dependent patient. Buprenorphine is only a mild analgesic. Because of strong binding to the mu receptors, if a patient's going to surgery, the buprenorphine must be stopped and the patient transitioned to a full agonist prior to the operation. And that methadone needs to be tapered to at least 30 milligrams a day before transitioning to buprenorphine can be attempted. All right. None of these things are considered to be valid anymore, and we're going to go over these, in turn. But let me first start with a slide that Dr. Panthappattu provided to me from a talk that he attended about discontinuing buprenorphine. All right. And so this is sort of summarizing things that we know about medications for opioid use disorder. The first is, how long should treatment last after getting someone on buprenorphine? Well, the short answer is at least 6 months. And that's because less than 6 months, there's a much, much higher risk of relapse if the medication is stopped. So we wanted to tell people when we're moving them onto buprenorphine, this is for at least 6 months to a year. All right. However, even if people have been on for a year, when you discontinue it, there is a risk of higher emergency room visits and overdose deaths. Okay. Long-term use side effects. Certainly, why do people want to get off of it? Well, there are side effects which are true for all opioids. You get hypoactive sex drive, erectile dysfunction, constipation. People who are going onto buprenorphine, a lot of their motivation is they want to get off of opioids. Right? And that's not unreasonable. But before they do, we really have to have a discussion about why is it you want to get off the opioids and how much of this is related to stigma, because we don't want you to go off of those and die. I have to tell you that in my personal practice, I tell patients, it's great you want to get off of opioids. I'm going to help you with that, but you've got to be on long-term injectable naltrexone, Vivitrol. Oh, there you go. I promise not to talk about Vivitrol. But you have to have a safety net if you're going to be going off of one of these medications for opioid use disorder. All right. So the one thing that I took from the conference, which is really key, and I think is like the showstopper information that came out of the conference, is that detox from opioid dependence is no longer a thing. The ASAM criteria book, which is used by, I think, a majority of United States to determine Medicaid payment for treatment of addiction services, took opioid detox off of their standards. It's now, they transitioned it to transition to medication for opioid use disorder. All right. And why is that such a big deal? Well, first of all, there is no evidence that clinical measures of tapering and stopping opioids in addicted people leads to prolonged abstinence. There's no evidence that it actually has a long-term effect, but there is evidence that opioid-dependent people discharged to home after detox and a period of abstinence are at high risk of relapse, overdose, and death. So the benefits have never been shown, long-term benefits have been shown to exist, and there are very, very significant harms, significant as in mortality. All right. And to sort of illustrate that, this is just one study, but I think this is this is a prospective randomized trial looking at people who went through inpatient detox for opioid use disorder and either sent home after the detox or kept into a long-term, I think 30 to 90 day inpatient stay, rehab stay, or given medications for opioid use disorder, buprenorphine or methadone, or both a long-term rehab stay plus medications for opioid use disorder. And you can take a look here that people who just were detoxed and sent home start dying. All right. When people who were kept in from the short-term detox to a long-term inpatient stay for rehab, they did better, but there were continued increases in mortality. People were sent home on buprenorphine or methadone, no further treatment other than the medications, definitely did better as far as mortality, and people who were in long-term rehab and medication did the best. All right. So this is a good, high-quality prospective trial and really brings home the point that detox from opioids is not a thing. It's not a evidence-based medical treatment. Very, very important stuff. And it's part of the official criteria for the American Society of Addiction Medicine. Okay, so I want to go here a little bit more into basically three types of patients that we're now facing with opioid use disorder, and thinking about how the opioid epidemic has evolved over the past 20 years sort of informs this. First of all, we have our legacy patients. These are patients who have chronic pain, who were started on opioids and are continuing to receive prescription opioids. At least half of them meet criteria for an opioid use disorder, or colloquially for addiction. Half don't, but they're on full agonist opioids with serious side effects, hyperalgesia, sedation, and not great pain control either. All right, and so we're having to deal with those people. It would be good to transition them to buprenorphine. You got polysubstance users, people using drugs recreationally, and they've developed some dependency on the opioids, and they're needing some kind of treatment for that. And then you have patients who have transitioned to high-dose illicit opioids, and they have severe tolerance. And treating with buprenorphine, these three groups is different. So we want to take a look at them in turn. First is buprenorphine for chronic pain. Now, I just want to point out this is a reference to a paper from 2009, and the paper is talking about the effect of buprenorphine on opioid receptors and how it's different than full agonists. But what I wanted to point out here is this conventional wisdom at the time. It says buprenorphine is a weak partial agonist. And what is the evidence towards that particular statement? This is something that was conventional wisdom and which was taught to me. Well, in fact, if you take a look at the effect of buprenorphine as an analgesic, measured analgesia not serum levels, but how the patient is responding to standardized pain. You see that, in fact, or after in 6 hours, that your buprenorphine is less effective than morphine. All right, I apologize for the fuzziness of the slide. But if you take a look here, in the first 2 hours, it's equally potent. And in fact, initially, it appears to be perhaps even a better analgesic than morphine. Which is very, very interesting, given the fact that buprenorphine has a half-life of 32 hours and morphine has a half-life of 4 to 6 hours. So why is it that the buprenorphine its analgesic properties are wearing off? There's something going on at the morphine at the opioid receptor level, which is not quite reflected by checking serum levels. But this is important information about thinking about how we're going to be dealing with buprenorphine for chronic pain. So for the approach to acute pain in patients on buprenorphine, the general accepted strategy now is biphasic. The first is you want to have enough long-acting opioid to prevent symptoms of withdrawal in people who are tolerant. All right. And so that's why buprenorphine, a long half-life, methadone, a long half-life, are the drugs that are used for opioid maintenance. They keep the patient above that threshold of withdrawal. But if you're going to be treating somebody who's got pain, then you've got to bump up the doses for pain control. And buprenorphine can be used for both of those things, especially if you're going to be giving it in split doses. If you do giving it for its long-acting effect for preventing withdrawal, you can actually give it once a day. But if you're going to be giving it for pain control, you really should be giving it 3 to 4 times a day, ideally every 6 hours, which will give you much better analgesic control. Okay. So, and I wanted to show this particular slide. Now, this is a little confusing because the lower bars are actually showing stronger affinity for the mu receptor, for the opioid receptor. So the opioid which has the greatest affinity for the receptor and therefore will eject other opioids from the receptor is buprenorphine. Ones with very low affinity, oxycodone, methadone. But even for morphine, which has a pretty good affinity for the receptor, it takes 5 times the concentration of morphine to buprenorphine to get into equilibrium, competitive equilibrium at the mu receptor. So that you're going to have to give 5 times the standard dose of morphine to have an effect of displacing buprenorphine from any particular mu receptor. But it's also interesting to see that hydromorphone, which is brand name Dilaudid, is not as potent as buprenorphine, but it's pretty close. So if you're going to be giving a full agonist opioid for acute pain in somebody who has buprenorphine, Suboxone on board, then you want to use something which is a very high affinity. And that would mean instead of giving them oxycodone or even morphine, give them some Dilaudid. You're going to have much more effectiveness as far as dealing with acute pain. All right. So this is a summary slide, once again from ASAM. And this is how you deal with patients with chronic pain or opioid use disorder who need acute pain relief related to surgery. And that is, first, continue the buprenorphine. Don't stop it. Consider splitting the dose to TID to QID for an analgesic effect. You can increase the dose as well for greater analgesic effect. And PRN dosing on top of your baseline dosing. All right. If you're going to use full opioid agonists, you want to use higher doses than would be needed in an opioid naive patient. And you would prefer to use opioids with high affinity like Dilaudid. All right. So one of the problems that we really have with patients, our legacy patients who are on long-term opioids, is it's hard to transition them over to buprenorphine because they know that Suboxone is used for addicts, and they're not addicts. All right. And they are offended by the fact that we want to prescribe them a medicine for addiction when they know for sure that they've got chronic pain. And some people we may question about whether it's really chronic pain or addiction, but we've got a lot of people who've got severe spinal stenosis, who have got very, very clear severe chronic pain and osteogenesis imperfecta. There's all kinds of diagnoses that brought people to be dependent on opioids. And how do we deal with those people? Well, one of the things that I personally do is I say yes, Suboxone is for addiction, but there is one of the active ingredients in Suboxone, buprenorphine, and that has been used for pain, and it's actually a great pain medicine. Now, this is an ad directed at physicians from Uncle Morty's company, Purdue Pharma, and it's a patch. And buprenorphine has been licensed by the FDA for pain since the 1960s. And Big Pharma has figured out the most effective way to provide this as analgesia is actually transdermal. Remember, you get the most significant analgesic in the first hour or two of the medication hitting the immune receptor. So a transdermal patch, which is constantly delivering, you're not relying on the long serum half-life, but you're delivering fresh buprenorphine all the time transdermally. That's a very, very good analgesic. And what I do for these patients, these legacy patients, is I tell them, listen, I'm not prescribing you Suboxone. I'd like you to have buprenorphine because it's much safer and it's very effective for pain. And I give them the patient handouts on the Buprans patch. I said, read about this. Let's talk about this. And then we try and do a transition. The little bit of problem with that is a lot of insurance companies won't pay for Buprans because it's so goddamn expensive. But we can say we'll give you generic buprenorphine, we'll dose it 4 times a day. It's almost as good as the patch for your pain, and you won't have so much sedation and hyperalgesia. All right. How do we get people onto buprenorphine? All right. We know it's a life-saving drug, but how do we get it? We were all trained initially that you really are worried about precipitated withdrawal. Someone's on a full agonist, you give them the partial agonist, you knock out some of that effect of the full agonist, and people go into precipitated withdrawal, and they are very, very sick. Here's another graphic sort of looking at that. Here you got your full agonist occupying your mu receptors, you give them some of the buprenorphine, it has a high affinity for the receptor, so it knocks out the other drug, and then people are in sudden opioid withdrawal. They're very unhappy, they're very sick, they can't tolerate this, and you've just failed your induction. And how do we deal with that? Well, we were taught people have got to be in at least moderate withdrawal before we initiate. We give them a test dose in the office, and then after a week or so, we've transitioned them onto buprenorphine. Very hard to do in the office. A lot of times you schedule them for an induction, they don't show up because they're back to using their heroin. So what have we done? We've transitioned to a home induction, which is basically the same thing. We give people a handout. This is from the Rand Institute. They have a publication on buprenorphine. We borrowed that. It's in our Suboxone Initiation Smart Set for home inductions. And that has been sort of the standard of care for the past number of years at the Institute. And pretty much nobody is doing in-office inductions anymore around the country. Everybody is sending people home with a prescription, you know. And so that's our standard of care. All right. So let me just present the case here. And this is one of a patient who presented to me. Yes? Someone was talking? Okay. 34-year-old man with stable heroin use over the past 15 years. He's got a new job. He wants to go back on Suboxone. He had been on it before. He bought some on the street and it made him sick. He said, an allergic reaction, nausea and vomiting, diarrhea, back pain. I sent off a urine tox. And not only did it have diacetylmorphine, which is known by its brand name of heroin, morphine, but also fentanyl and norfentanyl. All right. I put him on a microdose protocol and he was successful and repeat U-tox. He just had the bupe and marijuana.
Yeah.
He was at work. He was happy.
Yeah, if you don't oppose them, then you take away their power. They really don't know what to, people
All
don't,
right.
bullies don't know what to do if you're not, you know,
All right.
if
Dr.
you don't
Kalman,
give them the
could you mute
power
yourself?
over you. And
All right.
We'll try to
yeah,
mute
so
him.
that's good. I'm glad it
All right.
worked, sweetie.
All right. So
How
here's
was
the
your day?
microdose
Yeah,
method.
well, I
All
was
right,
supposed
that was
to be.
developed
I'm
here.
on grand rounds now, and then I have meetings late this afternoon,
right.
starting about 3 this afternoon.
If we
till
can
like 6.
mute
Can we
Dr.
mute
Kalman.
Neil?
All right. All right. All right. So at any rate, here's the microdose protocol that was first described by some addiction doctors in Switzerland. It was perfected out in Vancouver, and this was what was initially being distributed. It really got a lot of traction, really around the world. And there are a number of different protocols now being used. This is the basic idea. You start with a very, very low dose of buprenorphine. You very slowly start to replace the full opioids on the receptor with buprenorphine over a couple of days, ramping up from a very, very low dose, 0.5 milligram or less of buprenorphine. And then on day 4, you fully occupied all the receptors. It's been a slow rather than a crash landing, glide in, and the patient, which had a little bit of discomfort during the 3 or 4 days of initiation, is actually doing fine by day 4. All right. And there are a bunch of different protocols. One of the most important things is you don't have to stop the opioids. This is very important for people with chronic pain. You continue them on opioids. Here's a protocol, inpatient protocol, where you put them on methadone for the 3 days of the microdose initiation. And by the 4th day, they're fully on bupe and no withdrawal, easy peasy. This is something which requires every 3 to 6 hour administration done by nurses. It's an inpatient protocol. Here's another 48-hour microdose protocol that seems to work very well. But really, what's very, very interesting here is that by giving someone a depot injection of buprenorphine, these are preparations which deliver buprenorphine over a week to a month. And these injections are very slow onset because they're depot. And because of that slow onset, you're basically doing a microdose. And even though the package insert will say, don't give if someone has full agonist opioids for fear of inducing precipitated withdrawal, that's purely theoretical. And in the prospective trials, a lot of them which are funded by NIDA now, they are giving people who are showing up in emergency rooms in withdrawal because they were revived by Narcan and have a lot of opioids in their system. They're just giving them a shot of long-acting buprenorphine, and lo and behold, there's no precipitated withdrawal. There's no difficult initiation and giving people blister packs and detailed instructions about how to cut your buprenorphine strips into quarters to start. You just give them a shot and they're on their way, and they'll be fine. Here's a little graphic looking at the difference between giving an injection of depot buprenorphine with a slow onset as opposed to a rapid sublingual initiation. All right, so here's another case, 34-year-old with stable heroin use over 15 years. He comes in, he says, I can't do this anymore because he's lost a number of his friends from overdose deaths. All right. So he says he wants to get on Suboxone. He actually had bought some Suboxone on the street, but he got sick from it. Once again, same thing, nausea and vomiting, diarrhea, back pain. All right. Got a Utox, no surprise, some heroin with this metabolite, but lots of fentanyl and norfentanyl. All right. So what did I do? I put him on a microdose, and he was uncomfortable in doing that because he said, listen, I don't want to take this anymore. You're telling me to continue taking it for the next week until I'm on the buprenorphine? I said, well, I mean, you've been taking the heroin, for decades now. This is only for another couple of days. Well, back and forth. Can't you give me some oxycodone? So it was back and forth on this, but finally we got him to microdose. And on day 4, he was still very, very sick. He says, this is not working for me. And he actually went back to using the street heroin. So I said, let's try another technique. Let's try macrodosing. All right. You got to start withdrawal. But once you start feeling dope sick, then start taking some clonidine, some Zofran, gave him some Imodium, see how long you can finally tolerate it, and then take 2 strips of the 8 of Suboxone. Half an hour later, you're feeling sick, take 2 more. Half an hour later, feeling still sick, take another one. After 2 of 16s and 1 8, he's feeling a lot better. So what's going on here? All right. So the deal is with macrodose, you're keeping the level of buprenorphine low enough so that you're not causing a major displacement of the full agonist from the mu receptor and causing precipitated withdrawal. But if you give a massive amount of buprenorphine, then in fact you are not only displacing the full agonist, but you're giving enough stimulation of the mu receptor that you're not causing acute withdrawal. And this is not just theoretical. This actually works. There's a lot of prospective trial data which is showing that it works. Looking about it in a different way, and we're thinking about this patient who wound up after being microdosed still feeling withdrawal, is that it's not just displacement of the full agonist, but because of people who are profoundly opioid dependent, they need a lot of mu receptor stimulation to get them back into equilibrium. They've got a massive opioid deficit. And so you've got to give them very, very high doses of buprenorphine to be able to counteract that profound profound tolerance. And like I said, there's a lot of evidence. This is a trial of over 1,000 patients. We're using macrodose induction. The actual precipitated withdrawal was only 9 out of 1,200 people. Here in this other published study, precipitated withdrawal was also pretty rare, less than 2%. All right, so it really does work. And then finally, now here is Uncle Morty's Butrans patch being used for people who have profound opioid dependence. And this is a combination of a microdose and macrodose. Because it's slow onset transdermally, you get a very slow onset, which will not give you precipitated withdrawal. You can still give them their full agonists during the first day, and then it brings them up quickly, and then they're on a stable dose of medications for opioid use disorder. So there's a lot of innovation going on. A lot of very smart people are doing some very good research in actual patient care to be able to manage people who either are legacy chronic pain, people who need to be transitioned off of street drugs, or people who are suffering from profound tolerance. Here's a little summary here. The 3 different standards: high dose, macrodose, standard, which is what we've been doing generally, and microdose. Microdose is very good for legacy patients. high dose is the way to go for people who are profoundly tolerant, and for people who are using, who are addicted but not profoundly tolerant yet, our standard protocol works just fine. Okay, so quick summary, what I was taught about buprenorphine can be used to detox an opioid-dependent patient. Detox of opioid-dependent patients is not a thing. All right, forget that. All right, buprenorphine is only a mild analgesic. It works actually pretty well if you split the doses and if you increase the dose to a higher dose. All right, because of strong binding of the immune receptor, you got to stop bup prior to surgery. No, continue the bup and give analgesia with nonsteroidals. And if you need to use opioids, use a high affinity opioid on top of the baseline bup. And methadone needs to be tapered to at least 30 milligrams before transitioning to bup. Not really, just do a microdose. All right, so I'm going to stop right now. We've got about a little less than 15 minutes to talk. Let me just see. I'm going to stop sharing my screen right now and see who we've got here on the panel. I've got Dr. Panthappattu here. I've got Dr. Tarr, who's one of our addiction fellows, and is Dr. Urdanigo here as well? I don't see her. Yep. Hi, Talia. All right. So, do we have any questions that have been posted yet, or no? So let me share my screen again.
You do,
Yes,
Joe.
Dr. Lurio, you do have some
Yeah.
One
questions.
says, so does long-acting help with pain?
So does long-acting help with pain? All right. So the answer is, like I said, it does happen. It does help with pain somewhat. And my experience,
The
and then I
injectable
wanna-
one, the injectable one. that is-
yeah, the injectable one.
Okay.
Yeah, and the answer is I don't know. How's that for a lousy answer? But I'd like to hear what our other two panelists have to say about that. I think some people who say they have chronic pain, once they are on a good dose of buprenorphine, the pain is like an equivalent for their chronic withdrawal. And once that's being controlled with the medication, they're not feeling the pain. But there are some people who need some analgesia on top of it. And a lot of times have them taking a non-steroidal on top of the in the injectable works pretty well. I don't know, but I'm going to ask Joel, do you have any thoughts about that?
Yeah, I've found that when patients have complaints of pain, I tend to actually increase the dose, and that actually more often than not really tends to help with pain. And I do a lot of supplementation with either meloxicam or a higher dose of ibuprofen as an adjuvant for pain control. And the other thing also is I tend to actually utilize a lot of OMM at the office, because I think those modalities, when a patient really does see that they have multiple options on the table that can help them, it really does do quite a bit in terms of helping with pain control.
Yeah, I mean, I think as family doctors, I think we have an advantage to a lot of other people treating addiction because we're treating the whole patient. And we can look at some of those modalities. I don't know, Talia or Roshad, do you have any thoughts about treating pain in ambulatory patients who are on long-term chronic buprenorphine?
So I have to agree. I find a multimodal approach to be very, very helpful. Sometimes letting patients know that we're using buprenorphine as well as things like an NSAID or gabapentin can be very, very helpful in helping them. and letting them know that we're recognizing their pain, that they need other approaches as well, and letting them know that we're willing to work with them in engaging them with their pain, but definitely with a multimodal approach.
Yeah, I think if we're talking about the injectable formulation specifically, even people who are getting it for opioid use disorder without chronic pain sometimes do need additional Suboxone on top of the injectable. And so exploring what the symptoms they're having, whether it be chronic pain or continued withdrawal or cravings, you might then do the injectable with additional buprenorphine or another a full agonist opioid to help manage their pain further.
All right, so I have there's a bunch of different comments here, but there's one from Dr. Karp, which I think is really worth discussing as a panel. She writes, I have a patient 70 years old with spinal stenosis, prior back surgery, worsening quality of life. Pain management doc won't write for any opioids. I now give her oxycodone 5 milligrams twice a day. How would I dose bup for her pain? Already on nonsteroidals and gabapentin, duloxetine. All right, so let's start with Dr. Panthappattu. Joel, I mean, how would you approach this patient?
I think, I guess one question that I would have is, how long has the oxycodone 5 BID been on board for? Because if it's been a bit of a short period of time, I think this patient would be perfect for low dose initiation, because the oxycodone 5 isn't a terribly hefty dose, and I think your starting point is actually quite good. I think you went over the Bernese method, the low dose initiation. I think that would be quite good for this patient. Yeah, I think that's where I would start actually.
How about you, Talia? What do you think?
Yeah, I think, if this patient's been on this for some time now, I would agree with starting with the microdose protocol and getting them onto buprenorphine and then either dosing it TID or QID. Their morphine equivalents are about 15, so maybe they won't need 24 milligrams of buprenorphine. They might need something lower. And so once you're doing that Bernese method or the microdose, seeing what dose they start to feel comfortable or less in pain at. And maybe it ends up being something like 4 milligrams TID.
Yeah, and yeah, I agree. And I mean, one nice thing about doing a microdose initiation is that if you're doing it and part of the initiation is getting them up to 4 times a day. So you might have getting to two milligrams 4 times a day. You might find that turns out to be a very, very good analgesic dose for her. My main concern is that's a pretty low dose of opioids, 5 milligrams twice a day. So she might not need that much buprenorphine.
The other option, I guess, which depends on insurance coverage, and can get a little bit more nuanced, is doing something like the buccal film or the Butrans patch, because that is it's a microgram dose, so it is essentially doing the same low dose induction. And so I've had patients who have chronic pain and I've given them Butrans because it was covered, and that was great because they didn't need such high doses of morphine equivalents.
All right. All right. So someone has asked the question, are we allowed to treat primarily for pain? In the past, we were trained that we are not a pain clinic, so we can use bup for dependence, but not just for pain. I think I can answer that one pretty quickly. I think Suboxone is licensed for opioid use disorder, and we can prescribe that for opioid use disorder. buprenorphine by itself has been licensed by the FDA for pain since the 1960s. We can be prescribing that using our regular DEA license. And now, of course, buprenorphine, you don't need to have an X waiver. So I think that if we're prescribing straight buprenorphine for pain, we are in good shape. There's another question about use of buprenorphine for naive users in pain management. I would say it's a good modality. Just recognize that you're not, if you have an opioid naive patient, you want to start at a very, very low dose. If you look at the transbuccal buprenorphine or the transdermal, the doses of buprenorphine are very, very low. And so actually the analgesic effect is a very, very low dose. You're dosing at a much lower rate than you would for somebody who's addicted to street opioids or has been on high dose prescription opioids for a number of years. I have a quick case I'd like to share with the group. So let me just show my okay. So let's take a look here at if I can find it. Let's see. All right, 32-year-old female, severe opioid use disorder, uses IV fentanyl really every 2 hours while awake, intermittent cocaine use, recent overdose, presents in the emergency room in withdrawal, mild to moderate withdrawal, but with a big abscess on her left forearm. She's in severe pain in the arm, and she's presenting because she's in pain. She would love to get off of the fentanyl. She's tried buprenorphine in the past, but had precipitated withdrawal, and she just can't think of doing that while she's in so much pain from the abscess. She's uninsured and unhoused. All right, so in this particular scenario, how would you address the patient? So, Joel, what do you think? How would you address this particular patient?
I think the first thing that I would look at is really going a little bit deeper into the history in terms of what she has used in the past, her successes, her failures with trying to come off of these medications, because I think that gives us all a bit of insight into the route that we're going to be going. I think first and foremost, if they're coming in, if they have a large abscess that's causing this pain, you certainly want to address that source, number one. And you obviously want to treat their pain. That's certain, it's clear and obvious there. I think that is always a hugely complicating factor, because when patients have a certain history and they come into the emergency room or inpatient, it's a bit of a split brain for all of us in terms of how much do we give to address the pain aspect versus not continuing to cause an issue later on down the line. I think, we would obviously do urine toxicology, see or ask the patient what have they used previously, go through the UDS, see what exactly it shows, and have an open and honest dialogue and conversation with them. And then from there, the other thing, it's in the case, it says that they don't feel ready to start buprenorphine also. Addressing that, what are some of the challenges that they foresee with buprenorphine, whether it's not being used to it, not having access to it, because I think that that's something that was also very, very much highlighted, that access to buprenorphine is not equal in the United States. So I think that's also huge. And yeah, I would probably discuss look to see whether or not macro or a micro dose initiation would be a good option for her. I will admit, you know, I'm pretty familiar with the microdose induction. The macrodose is something that's new that I'm still learning about.
Well, you know, I think this is somebody who's in the ER. They're being admitted to surgery, and I think the most important thing is addressing both their pain and their opioid dependency, with the objective of being able to keep them in the hospital so that the surgeons can do their job. These patients are really notorious for signing out AMA because we're not addressing their needs of their opioid dependency and their pain. We're undertreating their pain and we're ignoring their opioid dependency. And then people sign out AMA. Well, duh. So I think addressing that, I mean, I think traditionally I would say someone like this, get them on methadone quickly with a rapid induction. Don't gradually give them just 30 milligrams. Maybe give them 30 milligrams 4 times a day until and give them short-term agonists until their pain is controlled. You can microdose, get them onto buprenorphine later on. But first get them out of withdrawal and also get their pain controlled. And then you can address the long-term issues. But this person is not only in withdrawal and severely opioid dependent, but she's also sick. And we've got to address all of those issues. Well, I'm 1 minute over time, and I apologize for that. As I mentioned, my real intention was to go to see the eclipse, so I'm sharing some of my photos from there down in Dallas. And thank you very much.
Joe, thank you very much. This is a lot to take in. Just realize how complicated this is, and yet, we're well positioned as family docs to make a difference with these patients. That's been your message, and we appreciate it. So thanks. Have a good day, everybody.